Hi, good evening, everyone. Welcome back to our webinar, yet another webinar by Beating Hearts. We have here with us Dr. Alexander Tan, a colleague of mine in Sunway. He's a consultant endocrinologist, previously a lecturer in University Hospital, University Malaya. So without further ado, let us welcome Dr. Alex Tan, and let's start with his talk.
Okay, thank you very much, Betty. So I think maybe the first thing you might notice is that I have actually changed the title. I've kind of made it a little bit more specific.
Okay.
Like Betty put there, diabetic emergency. So I kind of thought, look, let's focus on the hyperglycemic ones. And then I'm not a pediatrician, so the management of DKA in kids is going to be like, oh, you're giving fluids to kids is, to me, an adult physician, a scary thought, right? So I'm going to actually talk to you about adult hyperglycemic emergencies. If you come from okay, you might have seen these slides before, because full disclosures, I jury them from Jaya in so you might have heard his version of this talk before. The other thing is, if you happen to be working in Sunway Medical Center A&E department, you definitely heard this talk before, right? And then as you all know, Beating Hearts is no money one. Yeah. Okay.
No money whatsoever.
No money one, yes, no money whatsoever. So anyway, yeah, I mean, today, first day of MCO 2.0, you all got nothing else better to do than to sort of come and listen to me, come and join me in my bedroom. In fact, no, just kidding. Let's get to it. So I tell you, I mean, these kind of things that Jaya puts up, right? The diagnosis is definitely either going to be Dka or HHS, because that's the gist of this talk. So 20-year-old type 2 diabetic lady, HbA1c so recently had a double J stent inserted for right renal calculi. And so after inserted stent already, got some vomiting, got some lethargy. Then these are the usual medications that she's on. So standard kind of clinic kesihatan or government hospital stuff. A bit of insulin, a bit of statin, a bit of generic perindopril, a bit of aspirin, and a DPP-4 plus metformin combo. Okay, so afebrile, definitely very tacky, looks super dehydrated and renal punch positive. So already telling you the source of the likely source of the infection. Now your sugar is kind of 1920, your pH is 7.1, your bicarb is 5.9. Okay, PO2, PCO2, sort of not too bad. You got ketone 2 plus in your urine, and you got lots of bacteria, lots of leukocytes in your urine as well. You can see the urea and creatinine a little bit raised over there. So what is the possible diagnosis, Jaya would ask. And I'm going to actually tell you, when you have sort of 90-something people in a class, 100 people in a class, right? It's a bit difficult, and it's online. It's a bit difficult to sort of do the sort of a traditional walk up to you with a long ruler and tap on your table and say, what's the answer, okay? So
But surprisingly, sorry, can I stop you there?
Yeah, go on.
But surprisingly, all of them can actually type in. Yeah, and they can be very, we can be very interactive in that sense.
Betty.
No. Please
Okay,
type in what do you think it is. Yes, last week we had a webinar and they were so interactive just by typing in. So what is your question at this present moment?
How do I see them typing in?
Okay, what do you think the diagnosis is, everybody? Okay, Dka. Somebody said Dka.
Yeah.
Anyone else? Another said Dka.
Yeah. So you're correct, lah. Okay.
Okay, so everybody thinks it's Dka.
What is the next thing that would be kind of crucial? Okay. Now, this is something where if you work in a more up-to-date institution, if you work, I know I came from UMMC, I know they can do it there. But what would be the next test which would actually be crucial for you to nail that diagnosis of D, K, and A? So this might be something that, we have not practiced before, but modern medicine would mandate it, to be quite honest. The problem is
So
if
what
you
is
go out
the
into
next test that's
government.
crucial, everybody? Somebody say HHS. Somebody
HHS.
said,
Okay.
I don't know what is that. Somebody says serum ketone.
Yeah, okay, correct. So here's the thing. This is not going to be HHS, right? When HHS, Betty, is in olden days language, honk, right?
Oh, I see.
So
Okay.
HHS is the new way of saying honk. It's like, you know, yeah. So what is this? This is not going to be HHS. This HHS, usually you get blood glucoses. Your blood glucose will be like super high. Like 20 is going to be nothing in HHS. Like you'll get readings of 30 and above, 40, 50, 60, up to 100. Then the second thing about this is that this is a person who is obviously acidotic law, the pH is 7.11, right? The bicarb is low. And the guy who said basically that the serum ketones is required would be correct, okay? Because urinary ketosis is not exactly that accurate, right? So the problem is not many places in Malaysia can actually give you a serum ketone. So traditionally, we have always been using urine ketones. And I guess wherever you work, if you don't have it, you don't have it, right? Okay, but traditionally, this would be enough to make a diagnosis of DKA. However, in this day and age, what you should be trying to get actually is a specific value for your serum ketones. Having urine FEME with 2+ of ketones helps diagnostically, but you'll see later on in the management, right? It's like saying that you're trying to treat proteinuria, but you can only measure it with a number of pluses. Oh, it's went down from 4+ to 3+. It's a bit difficult in this day and age to know whether you're on the right track when you're treating true DKA. So the test which is crucial would actually be to get your serum ketones. And in addition to that, also the lactate is not raised. So this is not actually lactic acidosis. What you have is actually ketoacidosis. So that would sort of nail your diagnosis. And then if you, of course, if you want a full diagnosis, this patient has got urosepsis, likely to the recent J stenting, okay? Now, I'm not going to actually sort of take you through all of this, except to say a few things. The first thing is that there is some overlap between DKA and HHS. So you can see somebody with HHS level of glucose, say, for example, 50 millimoles per liter, but they could still have an element of DKA as well. Now, both of these, it all comes down to very similar managements. It's just that in HHS, you have to give a lot more fluids. In DKA, the really important thing is not to stop the insulin, because they have an absolute insulin deficiency. In HHS, if you stop the insulin a little bit, it doesn't matter. Usually we don't, but you have to give a lot more fluids. So when it comes to diagnosing DKA, it's not just you go and see the sugar is high, right? Okay, this is the Dka triad that you do need to qualify for. Okay, so first of all, you need a high glucose. The glucose doesn't need to be like super duper high. It's not like 25, 26, 27. As long as the glucose is within a hyperglycemic range above 11, or in fact, if you know that this patient has got diabetes mellitus, right? There are some guidelines now which will say you got background diabetes mellitus and you can prove ketosis either with a serum ketone of greater than 3 or ketonuria 2+ and above, together with a metabolic acidosis where your bicarb is less than 15 and your pH is less than 7.3. So you got ketoacidosis already, right? Against a background of somebody who's known to have diabetes, you are likely dealing with DKA. Of course, ketosis can occur with severe starvation, with alcoholism, etc., that kind of thing, lah. And of course, metabolic acidosis can occur with, acute renal failure from sepsis as well. However, when you have these three bad guys all coming in one patient, when you have a hyperglycemia, it doesn't have to be very marked. When you have ketosis as well as a metabolic acidosis, then what you're dealing with is actually DKA. So what would your immediate plan be? And he actually gave the answer down there already, i.e. give fluid law. So what fluid would you use?
Okay, let's see what they say. So somebody said A. So most said is A.
Yep.
Yeah.
Okay, that's fine. That's fine. Absolutely correct, right? The whole thing is that you just give fluid, okay? As long as it doesn't have any dextrose inside for this moment, the very important thing is to actually give fluid. Now, fluid, you have to understand, right? When you actually become a houseman, or when you actually start treating patients with DKA, fluid will be one of the things. It's not like you give the fluid first, tick the box, and then only you go and start giving the insulin, and then you go and start giving the antibiotics, and then you go and do insert the CBD. No, no, no. When you're treating somebody in A&E or on the ward for DKA, right, all these things happen at the same time. However, there is an emphasis on you putting fluids in, right? Because fluids widely available, right? It's much sort of easier to give rather than just a push of insulin. Fluids everywhere also got one, number one. Number two, when you give fluid to somebody who is in a metabolic acidosis, you immediately start to dilute their concentration of hydrogen ions. What are you talking about? So like somebody is in acidosis, right? We all understand acidosis. Acidosis, your pH is low. Your pH is low. Why? Because you have an excess, right, of hydrogen ions. And as soon as you actually give fluid, the first thing that will happen is you will dilute out the acidosis. And most of the time, these guys are going to be a little bit on the dehydrated side. This is actually also going to help. Now, when you have an acidotic person, they will also be having a high vascular tone. They have loss of noradrenaline pumping all and surging all through them. They will actually have a high vascular tone. They will have a degree of peripheral vasoconstriction, together with the fact that they are going to be hypovolemic. When you give fluid, it will pave the way as well for whatever insulin is coming in next, right? Because you will start them on insulin as the very next step as well. So it is very important that you give fluid. What fluid you would use? Zero, normal saline is fine. If, however, you have a patient who is shocked, right? The nurse comes and tells you the BP is 50 systolic, okay? Then you would also be going through your ABC, right? You would also be fully justified in giving them a colloid to sort of hit the BP up, right? You got to run the fluids fast. So a lot of this kind of thinking, a lot of the way that we treat nowadays is from the JBDS, Joint British Diabetes Society Management of DKA. You can see that it's quite an old document. And the good news is that we have our own CPG now, right? The endocrinologists in this country, honestly, they love to create CPGs for everything. We got a CPG on how to give injections, right? We have a CPG on diabetes in Ramadan. We got a CPG. We haven't got diabetes in Chinese New Year yet, but I hear that it's apparently going to be launched soon. No, just kidding. I wouldn't be surprised if you have a CPG on diabetes in COVID, right? So anyway, this is diabetes inpatient medical care, and they have this big section on hyperglycemic emergency. So you actually see that I've already covered the first part, the diagnostic criteria. You need to have those 3 diagnostic criteria, okay?
And the triad?
The triad, yes, correct. Okay. Now, when you start looking at this, right, the old way that we used to think about DKA is, oh, the sugar is high, the sugar is high. As long as we get the sugar is down, we should be okay. But there are multiple situations in which you can actually get a low sugar. You can pump somebody with like hundreds of units of insulin. But if you don't actually give them the fluids, if you don't actually raise their pH and stop ketosis, right? The aim of treating DKA is actually to stop the ketosis, not just the sugar. You have to think of it as a side participant, right? They are not the main bad guy. The main bad guy is actually ketosis. The very fact that you don't have insulin in your body, all glucose in your body cannot actually be converted over to be used as energy or stored, okay? So what then happens is your body starts to generate ketone bodies. Ketone bodies will cause you to be acidotic, okay? And you will be ill, right? And why this is important in this day and age, there is a class of drugs now that can actually push glucose out of your system through the urine. Now, if you just push the glucose down, right? Say you got a glucose of 15 and then you give somebody this new class of drugs called SGLT2 inhibitors, and the glucose come out of your pee, right? Your glucose can go from 15 to 9 after being given this drug. However, the problem is that you have not stopped ketosis. Okay, so measuring your ketone bodies, if you have the ability to measure ketones, right, it will be the target of your treatment. You have to try to get your ketones as close to zero as possible. Now, if you cannot, then you have to rely on the good old method of using urine ketone strips, right? Then you'll go through lah. Usually most DKAs that I see will be a 4+, then you have to wait for it to go 3+, 2+, 1+, 0. All right, but this is of course a very rough and not a refined way of doing it, right? They are labs and meters available for you to actually measure serum ketones, but I am very, very aware that in some hospitals in Malaysia where you work, this will not be available. So I'm just telling you that this CPG, written maybe a little bit from the point of view of, you know, in Putrajaya, they have all the bells and whistles. They can do every single test in the whole wide world. But if you're stuck somewhere where you don't have it, then you're down to your urine ketones and you're trying to aim for the ketones, urine ketones to become 0, and for your metabolic acidosis, of course, to correct.
Sorry, Alex, can I ask you a question?
Yeah, go on.
Okay. If we don't have serum ketone as a guideline to the treatment progression, is the pH in itself as good?
The pH in itself is as good, but not as good, because if you have got somebody who, say, for example, has got chronic kidney disease, they will be acidotic no matter what. So it can work as a sort of secondary guideline, but at the end of the day, you need what you're trying to do, which is coming to this next part, right? You're trying to fluid resuscitate them, yeah, okay, normal saline, and you're trying to give them insulin to shut down ketosis. So yes, the metabolic acidosis can work as a surrogate marker, okay? It's like sort of saying, oh, you know, I gave thrombolysis and the ST segments don't look so high, but actually until you go in there and you actually see the stenosis or the occlusion, you know, that would be the best thing. That would be the best case scenario, isn't it? Primary PCI, right? But, you know, if you don't have that ability, you work in somewhere where there's no, you know, facility, then yeah, sure, you can use the ABG and be directed by that. Because the next part I'm going to talk about is after you giving fluid resuscitation, you run your fluids fast. Okay. Now, again, here, this is ivory tower medicine, right? They are saying you need to set 3 IV lines on admission, 1 for maintenance fluid, 1 for bolus fluid, right? This is what they mean by fluid resuscitation, and 1 for IV insulin infusion. Now, this is really, if you can get 3 lines, if you can get a central line, fine, that would be optimal. But I have worked in A&Es in UH where sometimes you get 1 line also very difficult already, okay? Now, the concept behind this is this. You will be running large amounts of fluids. You will be running minimum, you can see there right at the top, 6 pints, okay, 125 mils per hour plus potassium replacement. This is going to be ongoing all the time. This patient, when he transfers from A&E to ICU or HDU or to the ward, this has to be running all the time. They don't want the fluid to be stopped, right? Then that's why they ask you for a second fluid resuscitation line where you can run boluses of fluid, because the understanding is that this maintenance 125 mils per hour, okay, may not be enough to bring somebody out of shock, right? May not be enough to increase your BP. So therefore, you may need to give boluses, run 1 point fast, run 1 point fast, run 1 point fast through this, but never ever stopping your maintenance fluid. And then of course you have a third line. You need a third line for your IV insulin, because this is the other thing whereby you do not want it to stop. Okay, so the fear and the mistakes that have occurred over the years with DKA management is down in A&E, okay? MO sees, Houseman sees, you know, whoever sees, okay? Oh, run 1 pint fast, okay, run another 1 pint fast, okay, now run another 1 pint over the next 1 hour, okay, run the next 1 pint over 2 hours. What they really fear is that after you run the 1 pint, run 1 pint, you don't give that maintenance fluid because you think you're out of the woods. This is why there's this logic behind it now. The Joint British Diabetes Societies started this way of thinking, started this way of management, and then this is why it's in our CPG to sort of say you need 1 line for maintenance fluid, you need 1 line for fluid resus, running your boluses and your boluses and your boluses, and then 1 line for your IV insulin infusion. And they want these dedicated lines because they are scared that when you only have 1 line, right, Okay, you want to set up your insulin pump that time, something goes and be sacrificed. The maintenance fluid is sacrificed because doctor has ordered IV tazocin or IV antibiotic or something like that, and then they stop running the fluids, right?
Okay.
To us, you stop the fluids is like you're going to go backwards. Once you stop fluids, you start to see the acidosis rising up again.
I
You
see.
start to see all that again. So this is the thinking about, if you can get 3 lines, big lines, if you can get a central line, all the best. But if you can't, then you need to understand that you need to make sure that the maintenance fluid and the IV insulin are not stopped, right? There is always going to be a transition between A and E and whichever ward, HDU, ICU, whatever it is, okay? So you got to make sure that the fluid is not stopped, okay?
There's a question by Chia Yan that says,
Yeah.
are there precautions when giving IV resuscitation such as if patients have congestive heart failure and cannot handle volume overload?
Yeah. So thankfully, most patients who are in Dka, so HHS is a different thing. You got to be careful because they tend to be older. If you got true Dka, hopefully most patients tend not to be having CCF. But once you do have CCF, yeah, you do need to transfer them to some kind of intensive care facility already, where you do need to ideally get CBP monitoring and urine output. Most of these people who are in true Dka, they are going to be dehydrated. So that first 1 pint that you run fast, most of the time is not going to be a problem. Yeah, but subsequent to that, after that, you are correct. You do have to be a bit careful. Ideally, you need to have a CVP line inside. Okay.
Yes.
Yeah. So yeah. So principle number 1, you got to give them fluid, right? After you give them fluid, you give them more fluid. Usually you have to bang a few boluses in, but you also have this maintenance fluid that is given, okay? That is going to be ongoing, right? That is not going to be stopped until they are out of DKA. And you can actually see that you're going to aim for urinary output of at least 0.5 mils per kilogram per hour. Now, sort of leaving the fluid to one side at the moment, the next thing is suppression of ketosis and reversal of metabolic acidosis. The way you suppress ketones is to actually give insulin, right? By giving fluid, you are diluting out the acidosis, you are diluting out the concentration of ketone bodies. However, you are not stopping the ketone bodies from being formed, right? You're just diluting it out and you're opening up your vasculature, right? The way you stop the ketosis is you need to give them insulin. Now, again, this is a slightly different way of thinking from before. Now, before that, to be quite honest, for making the physician's life easier, we have relied on this thing called sliding scale insulin. And sliding scale insulin, if you're not familiar with it, is you write in the drug cardex, if the glucose is 0 to 4, stop insulin. If the glucose is 4.1 to 6.1, give 1 unit, 6.1 to 8.1, give 2 units.
Okay, we get it, we get it.
Yeah, but now, in this day and age, when you're dealing with true DKA, you have to give this thing called fixed rate insulin infusion, which means that you just give the insulin. You do not stop the insulin in the time that they're having DKA. Now, what you then say is, hey, but doc, what would happen if the patient's glucose was going to drop to 3.0? We have to stop the insulin, right? So this is where that maintenance fluid matters. That maintenance fluid, right? Once your blood glucose drops less than 15, like personally I use 15, but in the CPG I see here they use 14, you switch them to something containing dextrose. Why do you switch them to something containing dextrose? So that you can give insulin. I know, right? This is a bit counterintuitive. Hey, but I thought we were trying to reduce the glucose. Not really. You're trying to give insulin. You're trying to give insulin so that they don't become ketotic anymore. You're trying to reverse the metabolic acidosis by giving the insulin. And if the insulin has nothing to work on, right? Yeah, Betty Tay, man. So you learn something. So if the insulin has nothing to work on, yes, your patient will hypo. When your patient hypo, the nurse will off the insulin. When the insulin is off, guess what will happen to your serum ketone level? It will go up for that 1 hour where it has been off before the nurse checks again. your metabolic acidosis will worsen in that 1 or 2 hours before the nurse checks the glucose again. So now the understanding and the thinking and the practice is a lot different. You give fixed rate insulin infusion all the time, right? And you start at 0.1 units per kilogram per hour, so that if you have a 60 kilogram patient, you start them on 6 units and you don't write a sliding scale. You just write in the IV drug Cardex, IV, Actrapid, Novorapid, whatever insulin it is, 6 units per hour, end of story.
Infusion.
The
Okay.
only thing that you change will be what fluids you give. You have to do a sliding fluids instead. So if your blood glucose is less than 14, or if your blood glucose is less than 12, up to you. You need to introduce some dextrose into the equation so that you can keep giving the patient insulin, so that you can keep shutting off ketosis, because they have also noticed that one of the big pitfalls is this patient who goes towards a low glucose. And you know, everybody writes a slightly different sliding scale. I've seen sliding scales where 0 to 6, they omit insulin, right? But once you omit the insulin, the ketosis will creep back in, right? Because DKA always has some kind of trigger, right? In our patient's case, it was pyelonephritis, okay? And that pyelonephritis is not going to be over already, right? The antibiotics work so fast. So yeah, this is the new way of doing it. Now, to be quite honest, you know, sliding scales are a great invention. It makes it easy for on-call doctors to exist lah, right? 3 a.m., you know, you gotta this one, you just write a sliding scale and then you go to bed. But it's kind of a bit like titrating inotropes and things like that. Sometimes you got to be able to be there to sort of say that, look, if I'm giving the patient 6 units per hour of insulin, and after 1 hour, the blood glucose is not improving, the ketosis is not improving, the acidosis is not improving, I'm sorry, you have to actually give more. You have to, this one, it's like giving inotropes. If you give inotrope and the BP is not rising, right? Okay, you don't spend the whole night giving the same level of inotrope, isn't it? You have to up titrate. Yes. So it's the same with your fixed rate insulin infusion. I would then recommend that you go in, if 6 units per hour is not working, you go to 8 units per hour and see whether your glucose starts dropping and your acidosis and your ketosis starts improving.
Okay. Can we stop here and answer a few questions? Sure. Okay, there's Shaswani asked if we can get can we use a triple valve line if instead of getting 3 lines? Can, right?
So the best place to treat the DKA will be in an ICU HDU setting, yeah, where you can get an art line, okay, would be great. Then you get your ABGs and you get a triple lumen, yeah. That would be.
I have a question from actually Facebook Live from this Dr. Francis MK. He must be about the same age like me. He says it's very interesting that about this fixed rate insulin and the fixed rate of the use of dextrose. He asked, how old is this understanding?
So this is something where we have always seen the mistakes, right? Of, oh, the sugar went to 3.9, right?
Okay.
Or depending on who writes the scale. Everybody writes a different sliding scale, right? Okay. Some people write the scale 0 to 5 omit. Okay. It's always been there. If you think about it.
Yes, true.
People omit the insulin and then they scratch their head and say, eh, why the next hour the sugar suddenly bounced back up to 15 and then the DKA bounced back again? It has always been there. Now, I showed you JBDS, okay? The latest update is 2013, but I think the first was probably 2007, 2009, where they started introducing this idea of the fixed rate
continuous maintenance.
Yes, and using dextrose to prop up the insulin, if you like.
I see.
So how long has it been in black and white? I think maybe in the sort of mid to later 2000s, Francis. Yeah.
Okay. Another question is from Pan. Say, what are the chances of a patient developing cerebral edema if rapid decrease in glucose level during treatment?
Yeah, okay. So I will get to that. So what happens is rapid decrease in sodium, rapid decrease in glucose. That is going to be one thing. So this is why the recommendation of your fixed rate infusion starts at 0.1 unit per kilogram per hour. 60 kilogram man, 6 units. 80 kilogram man, 8 units. And most of the time, this should be okay. This will not result in you having drastic drops in your glucose, like you'll go from 20 to 4. All right. If you're in that kind of scenario, then you're in trouble. You do need to prop them out with a bit of dextrose. And I would highly recommend, you know, if you're giving, let's say 8 units, I would highly recommend you halve it down to 4 first and then see what happens. So again, monitoring them in ICU, HDU would be the best, because you do need to have hourly blood glucoses. You do need to have hourly ABGs. You do need to have hourly serum ketones, right? There is actually a ketone meter available from Abbott, which is just a finger prick, the same like your nurse measures the blood glucose at the bedside, right? From a finger prick, there is a blood ketone meter which will give you the ketone readings as a finger stick reading. So if you have those I know we used to have them in UH, right? And UMMC, sorry. So this would be the ideal situation. Hey, Betty, were you saying something?
Okay, no, there are some more questions. No, somebody left their mic on, but there are some more questions. This late. Najiha asked if they read in a book where insulin is started with 2 units, then aim for CBS.
No. So Allah, you know. Hello, I'm Najiha.
Stop.
You give 2 units to 100 kilogram man, okay, and you give 2 units to a 30 kilogram ama, you know, it's not the same thing, right? So this is why this is why the insulinization is given as per kilogram per hour body weight, right? 0.1 is what you need to this one, right? So you look at a patient, you just agak-agak, you look at him, he looks like 60 kilograms, he looks like 80 grams, you give lah. You don't start at just 2 and then aim for CBS.
What is CBS actually? What is CBS?
Capillary blood sugar. Capillary blood sugar means that
I see. Okay,
hourly
glucometer lah.
The glucometer.
Another question is, if patient have IHT with poor EF or end-stage renal failure with Dka, should we give fluid boluses regime or just give? I think we need, that can only come with experience as you practice medicine. But the maintenance fluid must be given in this case for the moment, regardless, because the patient is so dehydrated. You don't have to worry about it at the moment about heart failure. Because if you don't give, if a patient comes with, let's say, kidney failure, acute on chronic renal failure, it will just get, renal failure will just get worse if you don't give fluid. So do not fear to treat a patient, but you need to know the basis behind why you're treating a patient. A lot of doctors have this fear of treating patients, and that is a bit odd. Okay, go on, sorry.
Yeah, so again, if you can, right, here's a little tip. If you can, intubate the fella, all right? If it's clinically warranted, you intubate, and that buys you a little bit of room, because if there is a little bit of pulmonary edema coming your way, if you have an intubated patient, you have a little bit of extra space, because many of these patients who come in, if they're really that ill, right? If you have somebody who is end-stage renal failure with CCF, oh my God, and they're also in Dka, he's going to be intubated lah, right? Most of the time, they're going to be intubated. It gives you a little bit of space to play with the fluids. A bit of pulmonary edema may come, okay? Then of course your pressures may need to increase, your ventilation pressures may need to increase, but that's a little tip that I can give you. But yeah, in many cases, that's just like what Betty said, you will come with experience and with managing these extremely ill patients. But if at your level, I'm assuming that you're sort of talking about Heisman, MO kind of level, you will need to call for senior help already to manage these guys with ESRF and CCF and Dka and some other infections.
Sepsis and sepsis.
And sepsis, yeah. You know, So yeah, this kind of patient, yeah, you need to get a senior help lah. Okay. So yeah, so where was I? So some people sort of said, do I need to give a bolus of IV insulin or not? So you see, the thing about IV insulin is that it will have a half-life of about 5 minutes, and 5 half-lives is 25 minutes. So your bolus just buys you 25 minutes of time. The most important thing is you need to have this ongoing infusion of insulin. And some people sort of say, well, what about giving a stat dose of IM or subcut insulin? Now, fast-acting insulin, so-called fast-acting insulin that you give to patients, the traditional teaching is that we tell patients in outpatient is you inject first, then until you wait for half an hour, then only you makan. Now, in an emergency situation, right, you want your insulin to act now, and you have a vascularly compromised patient, their vasculature is already constricted and shut down. If you give IMSC, IM or subcut insulin is not going to be enough. So the best thing is still, don't be fooled into thinking that I have given this patient 20 units stat subcutaneous is going to actually absolutely help. Well, first of all, it's going to be delayed. Okay. Second of all, it might not actually have any meaningful effect in your bloodstream because you're shut down and you're septic. So the best is still IV insulin. And just because you give IV as a bolus, that does not get you anywhere. That IV insulin that you give is only going to tahan you for about half an hour. You need that infusion, right? Yeah, so that is just something else to tell you all about. Okay, so the important thing is that you do need to monitor these patients. You need to monitor them like hell. So they ideally should be in an ICU HDU type setting, right? And what are you monitoring? Monitoring exactly like what it says, the fluid input output, how much is going in, how much is coming out, if any is coming out. Hopefully there'll be some coming out. You're monitoring your oxygen saturations, making sure that you're not putting them into pulmonary edema. You're monitoring their CVP. Hopefully you have a CVP line. You're monitoring the resolution of ketosis, and this is best done by using a ketone meter. Now, if you don't have a ketone meter, you have to go for ketonuria already law. You have to hope that, in the first hour, you might see that it's still 4+, but it's actually improving. Okay. Then the problem also is that the kind of ketones that you measure in your urine are not actually the absolute whole truth. There are multiple types of keto acids, and the one that we kind of are recommended to measure is this 3-beta hydroxybutyrate, which is best measured in your blood. However, when you look at the urine, some urine ketone meters, when they actually dipstick it and then see what color, whether it's 3+, 4+, or 2+, okay, it doesn't always measure the 3-beta hydroxybutyrate, so it may be a bit inaccurate. So in that case, yes, you can use your metabolic acidosis as a surrogate measure. Okay. So is it going to be an ABG or VBG? To be quite honest, it doesn't change much of a difference. Okay, so what I'm giving you is these concepts, right? That you give this maintenance fluid, you give the boluses as required to prop up the BP, right? To do fluid resuscitation. I'm not telling you exactly how much to give. Even this guideline of giving 1 to 5 mils per hour, that is open for interpretation. You might need to give more, right? You might need to give 8 pints over 24 hours in a highly dehydrated patient. So yeah, and then the fixed rate insulin infusion, you start at 0.1, but don't always think that by going at 0.1 units per kilogram per hour, you're going to be safe for the whole night. It will work, right? You do need to monitor back the blood glucose and make sure that they're not drastically dropping. You did need to monitor also because sometimes it just doesn't shift. Okay, the sugar remains at 25, right? You're giving 6 units per hour and it just doesn't shift. So it's just a starting point. Okay. Yeah, so I did some animations. How would you give the insulin? Yeah, I already went through all of that. How frequent would you monitor the blood glucose? The answer is actually hourly initially. All right. You can move to 2 to 4 hourly after maybe your patient's ketosis has actually resolved. Okay, what else do you need to monitor, and how often? Actually, I've gone through that already, monitoring them for ketosis. Now, there's one other big part that I haven't talked about, which is a side effect really of the treatment, and that is your potassium. Okay, so as all of you will know, insulin will cause you to become hypokalemic, and so you will need to end up giving some potassium replacement. Now, what I would actually recommend is that the first fluids that you give are actually free of potassium until you can get some kind of potassium reading back. Because the problem is when you have a brand new patient in front of you, you don't know. You cannot assume that just by giving insulin that it will cause them to be hypokalemic. If they are starting in potassium reading is say 7.0, right? You don't want to be giving them potassium. Why could it be 7.0? Well, they are in acute kidney injury, they are in AKI, right? They are in sepsis, they are vascularly shut down. So you do need an initial potassium reading. Your initial fluid resuscitation does not contain potassium, but once you have a potassium reading back and they are not hyperkalemic, you do need to start giving already some form of potassium replacement, with the understanding that when you give insulin, it will lower their potassium. So you want to try and aim for the potassium to be between 4 to 5. Yeah, and sort of repeating it every 6 hours and changing your potassium in the fluids accordingly. Now, most of the time you end up giving somewhere between, so in Malaysia we use grams of potassium, grams of KCl, somewhere between 1 to 3 grams of KCl. So don't be afraid when you give insulin and to a normal kalemic patient, you will it will be actually quite a powerful thing to reduce their potassium, right? So sometimes I've been writing like 2 grams, 3 grams KCl per pint. Some people sort of look at me and say, wow, that's a lot. But then when you see that the potassium has actually gone down to 2.5 or something like that, you begin to realize that it's actually necessary if you're giving somebody lots and lots of insulin, like 8 units per hour, 10 units per hour kind of thing. Okay. So yeah, that is your potassium. Always get a first potassium back to guide you, right? You know, first potassium comes back at 6.4. Ooh, definitely you need to wait for the fella to come down with some insulin first. Then only you start the replacement. Of course, you can also do fast corrections. If at baseline you find that your potassium is already like 3.4, 3.2, you can do some fast corrections as well as adding in the potassium to your maintenance fluids. Okay. So I would sort of say that, you know, most DKAs, I would prefer them to be in ICU, HDU, but here, you know, the guideline basically says that if they're elderly, pregnant, have heart failure, kidney failure, serious comorbidities, put them in ICU, HDU. But, you know, most of them, I would at least want to put them in ICU, HDU if possible. Okay. So now, somebody asked earlier about avoiding cerebral edema. And so you can actually see here, what you're trying to do is trying to bring down your ketones by about 0.5 millimoles per liter per hour. What you're trying to do is increase your bicarb by 3 millimoles per hour. And you're trying to bring the blood glucose down gently by 3 millimoles per hour. You don't want to see like them going from 18 to 4. If that's the case, you're giving far too much insulin, or you're not giving any enough dextrose. Okay, so that fixed rate insulin infusion, you're going to have to sort of say, okay, well, maybe 8 is a bit too much. Let's go down to 6, or let's go down to 4. Okay, so there's a lot of monitoring that needs to actually be done. This is why I would sort of highly recommend you know, if you're going to be doing so much blood taking, if you're going to be doing so much monitoring input output, they don't belong in a general ward for me. Even if they're not elderly,
yes, true.
you know,
Very true.
you should put them in the ICU, HDU already. You monitoring so much, right? So yeah. But
so
maybe
Balkis has a question for you.
yeah,
Do we
go on.
wait for the potassium level before giving insulin? I think let me answer that. Let me try to answer that. No.
Correct. Yeah, just give the insulin bagus. Yeah.
What's your language This is
Oh, okay.
no. We don't. You see, this is an emergency. This is something that you need to treat as immediate as possible. That is the take-home message here. Okay, the take-home message here is to start on insulin, and most importantly, to start on a maintenance infusion of insulin. Okay, but immediately after you have started your drip. Okay, if I can learn that, you can learn that. IV drip, insulin, it is not rocket science, but it has to be smooth. It has to be one after another. It has to take seconds to think. You have to think on your feet. As housemen, as medical officers, when you come to emergencies like this, you don't wait. You don't wait for the potassium to come back. Okay, go on.
Yeah, no, absolutely lah. Yeah, look, at the end of the day, Balkis, I know I talk long time about hypokalemia and all this kind of thing lah, but look, at the end of the day, you're correcting your potassium is no big shakes lah. It's not a difficult thing. Trying to get these guys out of ketosis and acidosis, that is a big problem, you know. You can fast correct potassium 2.5, you fast correct lah, you know, your fast correction is like over 2 hours, is okay, right? But you will find that to correct them from Dka takes like half a day, 1 day, right? Many hours, and it's not that easy. So yeah, you give the insulin, you give the fluids, nobody's going to come and kutuk your head, right? But if you don't give the insulin, you don't give the fluids because you said I was waiting for the potassium, right? Betty Tay is going to jump out of the computer screen, all right, and kutuk your head. Okay, so yeah. Yeah, so I guess all that right, this particular CPG, what they actually do is they compress all that theory and compress all of that into actionable points, which you can download the thing from the MEMS website and the KKM website. And to me, this would be the page that you want now. All that about like the theory behind why we do FRII and why we sort of look after hypokalemia. That's all the understanding behind it, right? Every patient is different. But if you just want the steps and things like that, you want something to paste onto your wall, this would be the sort of, how you say, the gist of it lah, right? What I like here is that they actually give you, you were talking about potassium just now, right? Here they actually recommend how much potassium that you have to give. Unhelpfully, they go and put it in millimoles potassium, which is not how we work in Malaysia. Millimoles is how they work in the UK, right? So just as a guidance, 1 gram kCl is about 13 millimoles of potassium lah. So if you see here, if you have a sort of normal potassium level, right, serum potassium level, and you want to be giving them 20 to 30 millimoles, that will translate to about 2 to 3 grams of potassium being given per pint. Okay, so yeah. Yeah, that's another one thing as well, which is something that you have to be very careful about. If most of the time, you know, you are worried about giving potassium, right? But most of the time, as long as if your patient has a normal renal function, okay, it should be okay. The body will be able to homeostatically kind of adjust for it, and you will be able to peep your potassium out. But if you got an anuric patient, then you have got to be in HDU. You got to be watching the potassium like a hawk lah. Right? Yeah. So what they actually say here about withhold potassium replacement if there is no urine output? Yeah, in a sense, but you know, I have seen also before like oligoanuric patients with potassiums of 3.0, and you are not going to treat that, right? You have a potassium of 3.0. You can give some lah. You can give some, just not a lot, maybe about 0.5 grams, and then re-measure back again. Okay, so yeah, this is the summary sort of first 60 minutes. So yeah, then there are other things to think about as well. Like if there's no clear cut right on your clinical history taking, you need to think about like people, why are they suddenly going into DKA, right? Why, what has happened? Usually there's some kind of infection going on in teenagers, in some patients with type 1. It could be due to just accidental or purposeful omission of the insulin. Now, there's this also sort of side thing. Some people advocate in very severe DKA giving IV bicarb. You have to understand that bicarb is only given in severe DKA where your pH is less than 7. And that bicarb is only temporary, right? It's only temporary because if you don't shut down ketosis, if you don't shut down acidosis, if you don't get rid of your hydrogen ions, right, you cannot be forever pumping bicarb into them. You need to pump the insulin in. So the bicarb will buy you some time. Okay, it will buy you about half an hour, 1 hour. You will stabilize your pH a bit. But because you don't shut down the ketosis, acidosis, it will come back and bite you. So it's just a time buying measure. And some people actually don't even bother to give it because they sort of said the more important thing for me to actually give is to actually give the fluids as well as the insulin. Okay. So again, you will have somebody who will be in HDU ICU, so a bit of Clexane or low molecular weight heparin. So what they sort of say here is that you want to give them a fast-acting insulin rather than a basal kind of insulin to treat this. Yeah, because look, this is an acute emergency. You don't want your insulin to be the kind of insulin that sort of acts long-term. You know, you got your bolus insulin with short-acting and you got your long-acting, right? It has to be written in black and white so that people will follow, okay? But you do not treat DKA with long-acting insulins, okay? So this is just common sense, but you know that they did sort of write it down, okay? No basal insulins. So how do you know you're on track? Right, glucose by 3 millimoles per hour, ketones by 0.5 millimoles per hour, bicarb by 3 millimoles per hour. This is how you know you're on track. DKA. How you diagnose is D, right? High sugar, K and A, high ketones, acidosis. And how you know you're on track is in all these three things are actually improving. Now, if it's not, then you need to give more insulin to shut down the ketosis and to shut down the acidosis as well. Okay, the glucose again, not so much. You know, the good old days, if you like, Betty, was like, oh, the sugar is 8 already. Okay, I think we should be on track, right? But it's actually a lot more complex than that. You're actually really trying to shut down ketosis because there is this thing nowadays, euglycemic DKA, because if the glucose is pouring out through the urine, the glucose can be low, but you haven't necessarily gotten out of the woods because you're still ketotic. So yeah, so this is it. Now, how do you know you resolve? Once your blood ketones are less than 0.6 and you have actually normalized your acidosis, your ABG, your pH, and your bicarb. Okay, so yeah, that is that. Okay, so anybody else was asking questions or not?
Any questions, please ask. Okay, let me ask a few questions.
Sure.
What is the mortality rate for patients with DKA?
I don't know. I can't remember, but it's lower than HHS.
Okay. And when a patient has DKA, does it mean that eventually he has a insulin dependent kind of diabetes?
Not necessarily.
Not necessarily. Okay.
Yeah. So you can have patients who will recover pancreatic function later on. Yeah. So like say they come in with florid acute pancreatitis, they can be in DKA, but after antibiotics is given, maybe they, you know, whatever necrotic parts of their pancreas has been sort of excised, etc. They can have some residual pancreatic function. So do not assume that DKA is absolutely going to mark you as insulin dependent for the rest of your life, i.e. type 1. No, by far, I've seen patients come out of DKA, but still not require insulin, I mean, yeah.
Any questions? Any other questions?
My subtitles are really interesting.
Subtitles.
Yeah.
Yes.
Okay.
Ketosis. Yeah, key and ketosis. I've been reading the subtitle, and this is the first time actually that I've seen subtitles. Is it something that you put in?
It is useless lah. Got key and got ketosis.
Yes, but I never seen a subtitle before in the slides of any presentation. What are you using?
You buy me some nasi lemak to eat, then I teach you how to do it.
Don't worry, I will Google, and I'm very resourceful in getting information without buying anyone
you just buy
anything.
me
Okay.
nasi lemak lah, then I'll tell you how to do it.
Doctor's Lounge also not open, okay?
Aiyo.
Okay, any more questions? We have done, why everybody so quiet suddenly? Because we scolded Balkis. Sorry lah, Balkis. Okay,
Sorry,
what
sorry.
investigations, Balkis has asked another question.
Sure.
What investigation to do to find the causes of DKA? Okay.
I mean,
Basic.
you
I think there was a slide. There was a slide that you said. Okay, there was a slide before this that Alex shared, and then he said that the precipitating factors for DKA usually sepsis and acute coronary syndrome.
Yeah.
Yes,
Stroke.
a stroke. Okay,
Yeah.
it could be many things that
Yeah.
actually tip the patient over DKA. So keep all those in mind. So when you investigate, you do all these tests. So for example, you want to know whether it is acute coronary syndrome, then you do your cardiac enzymes, your ECG, blood culture, ESR, total white. Yeah. So those are the tests that you would.
So the concept that I'm trying to sort of put forward is basically that you need to look beyond the DKA. There's usually some kind of trigger, some kind of precipitating factor lah. Don't think that, oh, okay, you know, I diagnosed the DKA, all well and good lah. There's usually something else going on one. So that's just why I put that up lah. Now so that something else going on is sometimes you can just tell lah from from clinical medicine. You know, renal punch positive, got pus flowing out of the urine. Okay, so left basal crepitations, temperature 38 degrees Celsius. Then you, of course, you learn medicine, you investigate accordingly, you know. So yeah.
So before you go into investigations, a lot of times from your assessment of the patient history taking and examination, you already have an a rough idea of what actually is the cause of what caused this DKA to come about. Okay, Lim Tay Peng asks, oh, my surname is in his name. How common do patients get? Okay, how common do patients get DKA without having pre-existing diabetes? Can you get DKA without
okay, so what happens is you can have scenarios where this is the first presentation of diabetes that has been seen before, right?
Yes.
The day that you get DKA is the day that you're diagnosed with diabetes, okay? So that's one thing. Then there are also patients who have a pancreatic insult, right? Acute pancreatitis from whatever, okay? So they don't have pre-existing diabetes, okay? But then suddenly they got florid infarct in their pancreas lah, or some sepsis in their pancreas lah, then their pancreas fails, okay? And they can get DKA. So that is also actually also possible, right? So these are some scenarios where you are not known to have diabetes, and then boom, you get DKA. Yeah.
So possible, but probably they already have they probably already have existing diabetes, but they were not diagnosed.
Not diagnosed. Yeah. Or acute pancreatitis lah. Yeah.
Okay, Farah Hanani said, how episodes of DKA impact the management of diabetes in primary care, especially those with multiple comorbidities? How episodes of DKA impact the management of diabetes in primary care? Now, DKA, I'm not sure what the question is about, but DKA is not a presentation that you can manage in primary care. It must at least be in a high intense, in a
acute hospital lah. It's an acute emergency, right?
Yeah, it's an acute emergency.
You have to.
So of course, if you see in the primary care, you have to accordingly send the patient to an ER. It is very important. Okay, without treatment, I think the mortality is
100%.
Definitely,
Without treatment, the
100%.
mortality is 100%, correct?
100%.
Yeah. Yeah.
Yes. So if that's, I hope that answers your question. So even in primary care, it is important you pick up DKA. Okay. I don't want to show off, but actually, I had a patient who came with acute coronary syndrome, and then she actually has no symptoms or signs of heart failure. Okay. Her sugar was not to say very high, it was in the teens. And I referred to one of my colleagues, which is not Alex. Okay. But what I found very peculiar was her breathing. I found her really like tachypnic, but lungs were clear, chest x-ray was clear. So I decided to do an ABG on her. And true enough, she was acidotic. And I have to say that my colleague was very proud of me, that I diagnosed a
Oh, I'm very
DKA.
proud of you. I'm very proud of you. Cardiologist diagnosed.
Yes,
Yeah.
cardiologist diagnosed an DKA. But it was actually just by observing how she breathed. Now, acidotic patients will look tachypnic to you, definitely. And their breathing is not the same as a patient with fluid overload or pneumonia. It is not so labored, but it is still tachypnea. So that is also an observation that you will learn as you go along in your career, in your journey into medicine. Is there any other question?
Betty, could you smell or not? Could you smell the ketones or not? Some
No,
people
no.
can smell, some people
Yes.
not one.
No, if really bad, I've smelled before. Yeah. Some people can smell the sweet smell of ketone. But this lady, no. This lady was actually like you and I, very well. It's just when I look at, her pH was 7.1 something, She's so well. So it was very interesting.
Yep.
Fiona said, sorry, I think I missed it. When to start the dextrose again? Is it the same time? Fiona Shaw
No, so
on
okay. So
let's
the
go through that.
the dextrose, different people start at different levels lah. So personally, I start whenever the blood glucose goes less than 15. In the CPG, you will notice that it says 14. And I think one of the societies, the Joint British Diabetes Societies, they put there 12. Okay, so somewhere around there lah. Once you sort of, okay, I just follow the CPG. Once you hit 14, okay, it's still high. Yes, you're giving insulin, but you actually want to give some dextrose so that the insulin can work. Now, here's the thing also. In an acute setting, right, having a slightly high glucose is actually not that detrimental if it's just for 1 or 2 days, right? Some people that I've given this lecture to will say, wow, you accept 15, 14 still okay, man. I thought we have to drive it down to fasting 4 to 6, postprandial less than 8. I mean, that's for chronic hyperglycemia. In acute hyperglycemia, right, it's kind of like treating COPD. You don't actually need to have 100% SpO2, right? As long as you have something above 90%, sometimes it's okay because you shut off their hypoxic drive, right? So in this scenario, don't be afraid of sort of saying that, oh, okay, the glucose is now less than 14, is 13.5. I'm going to start some dextrose saline, giving the dextrose so that your insulin can work. Yeah, so don't be scared of that.
Okay, we have some more questions coming in now, more and more. Okay, DKA causing pseudo hyponatremia? Can you explain this and how do we manage it?
Yeah, so usually pseudo hyponatremia doesn't occur within the confines of DKA. It usually occurs in like crazy high glucose. So this next case I was about to show you, I'm just going to talk to you straight, right? This is a case of HHS, what we used to call HONK, hyperosmolar non-ketotic.
You have another case?
Yeah, so no, it's okay. So what happens is now we call it hyperglycemic hyperosmolar syndrome, right? So they are hyperosmolar. They have got honey for blood. They have got really super thick blood. So you can see in this case that the glucose is 71.2. Now in those cases, what you will actually get is an erroneous laboratory reading of your sodium. So you will get back a reading of like the sodium is 129 when the true sodium is 153. And of course, you will recognize that 129 and 153 is completely different. Okay, one is hypo and one is hypernatremia. The type of fluids you give would be completely different. Okay, so whenever you have this setting where you have super crazy high glucoses, you will face pseudo hyponatremia. Now, I actually prepared this. There is a formula that you can use for pseudo hyponatremia. If I can just sort of get to it. Now, what they actually kind of teach you is that you use this measured sodium plus 0.024 times serum glucose minus 100. And if you are actually using millimoles, you divide by 100 again. Now, what I actually do is I just do a much simpler formula because you just need to agar where you are, which is glucose divided by 3. So if you have a glucose of 60, for example, okay, I'm going to input this into the formula, and the measured sodium in your lab report is, let's say, 127, right? What the formula will actually tell you, depending on which formula you use, is that the true sodium is actually 151, not 127, right? This is your correction for that very high glucose. But if you use the way that I do it, which is a bedside manner, because I can never remember this 0.024 times this minus 100 divided by 100 business, is I take the glucose and I divide by 3. So if you take a glucose of 60 and you divide by 3, you get 20. You add the 20 to the sodium of 127, you get about 147. Now, I understand 147 is very far away from 151, right? But for bedside practice, you know what you're going to do already. This guy is hypernatremic, right? He has a sodium of 147. Okay, you need to bang the fluids in now. So in many cases, right, when your patient first presents with HHS, their glucose is something stupid like 60, something stupid like 70, 80, right? Yeah, your jaw is dropping, and you see a sodium of 12 something, 13 something. That's not the correct sodium. It's going to be usually hypernatremic instead.
Okay. Emily asked if the patient had existing subcut, the insulin is met, do we administer them together with a fix? I think
no lah.
Don't worry. Don't worry about that anymore. Now concentrate on that insulin infusion and getting the ketosis down and the acidosis down. So look at the three things that we were talking about. Okay, the D, the K, and the A.
Yeah.
So forget about the subcut insulin. Forget that. You know. So Su Wei has answered that. Okay, we have answered everything already. And then yes, if you have a patient with a sugar of 60, a blood that is red, doesn't it make you think of syrup bandung?
Syrup bandung.
You add water, it becomes syrup bandung immediately.
Yeah. So yeah lah, I mean that is HHS, right? So you do need to, first of all, you need to bang fluids in lah. Okay.
So do you want to present some of your HHS slides?
No need lah. What is sort of very similar. Okay. But the thing about it is you will see crazy high glucoses, right? Blood glucose, you can see here more than 30. Your serum osmolality, you can send it off to the lab and get the result back if you're in an advanced hospital like UMMC. If you can't get it back, there is a formula that you can use. And the formula I'll show it to you earlier is 2 times sodium plus glucose. You can do 2 times sodium plus potassium lah. It's very simple. Serum osmolality. What is osmolality? You just want to know how concentrated your blood is, right? What is the #1 cation in your body? That's going to be sodium, because what is normal sodium range? 135 to 145 millimoles per liter. The next biggest one is potassium, and that is only between 3.5 to 5. Okay, so some people don't include that in the formula because they say, yeah, 3.5 to 5 is not going to make a big difference. Okay, the main one will be actually sodium. Why do you times the sodium by 2? Because you are going to agar that for every cation you will have an anion. For every sodium you will have a bicarb or a chloride or a carbonate or something like that, right? So if you consider all the ions in your blood forming a concentration, and then you consider that there are other things that will bump up that concentration, i.e. glucose, okay, because your glucose is going to be 30 millimoles and above, then cations plus anions plus your glucose will give you this serum osmolality. And if it is above 320 and your glucose is high, you have got a diagnosis of HHS. Now, if you have a normal bicarb and pH, the patient doesn't have coexistent DKA lah. But if they have got a low pH and bicarb and they have ketones, then you have got both occurring at the same time, DKA, and that's usually quite rare lah, but it can occur. They are severely dehydrated. You do need to give a lot more fluids over time compared to DKA. But the problem with many of these patients who get into HHS, you see, DKA can be quite acute one. You can get an acute pancreatitis, right? You can get some kind of weird infection in your pancreas, and then you can get a DKA within a matter of hours. But usually HHS is a chronic process where they have just not had enough insulin for weeks and months, and their sugar has crept up from 5 to 6 to 7 to 8 to 9 to 10 to 29 to 30 to 31 to 32, 33, 34, right? So this is usually a more chronic onset. It can be acute, but the problem is that many of these patients will be a lot more elderly. Many of these patients will be the difficult ones. They will have concomitant HHF. They will have concomitant chronic kidney disease. They may have concomitant COPD, right? So hydrating them is going to be a lot more tricky, a lot more difficult. You want to bank fluids, but you have to be careful. You need to send them to HDU and put a CVP line in.
Mortality is higher with
much higher. You're sort of like, if DKA was sort of nowadays in modern medicine, I would think that DKA is kind of like in advanced countries, the mortality will be like something like 5%. In Malaysia, I don't know, maybe it's about 15%. I don't know exactly. But for what do you call this, HHS, you're looking at 20 to 30 kind of percent, if not higher. Yeah.
Okay, we have spoken for about 1 hour and 15 minutes.
Yeah.
And we have not covered everything. Maybe we need to invite you back again. It's been a very, very interesting session for me also.
Yeah.
And if there's any last minute questions, we can take 1 or 2. If not, I have to go back and attend my patient in ICU.
Oh.
Anyway, no, nothing much. Just to know where he has been transferred to. Don't worry.
Yeah, you just make a phone call, Lord.
Yes. Yeah. Okay. Anyway, thank you very much, Alex. Thank you. I see you again tomorrow. For sure in the hospital. Thank you everybody for joining us today. Next week, we have another webinar by Roshan. Roshan is actually a pediatric orthopedic surgeon. And Roshan is actually you know Roshan, right?
Yeah, I know.
Roshan was from UH too.
Yeah.
So join us next week. And I see you guys. Have a good MCO ahead. Yeah, I know. Anyway, stay safe and take care.
Okay.
Bye. Thanks,
Perfect.
Alex.
Bye, everyone.
Yeah,
Good night.
bye.